Okay, great. Well, good morning, everybody. That was a nice synopsis, Aaron. So today we're going to talk about traumatic brain injury using this case as sort of a launching point. And we're going to talk about various elements of traumatic brain injury. We're going to focus primarily on the acute pathophysiology of brain injury. And as soon as we figure out how to get our slides going, what we're going to focus basically on are various elements of the pathophysiology along a time course. And we'll get to the slide where we show the time course of traumatic brain injury, because the time course actually plays a significant role in the ongoing evolution of events. We'll start a little bit with the overall overview of traumatic brain injury. So we'll talk a little bit about an overview. We'll talk a little bit about the types of traumatic brain injury, and then we will go through the key elements of the pathophysiology of traumatic brain injury. And this patient actually displays several of them. We're not going to make it, we don't have enough time really today, but we're going to go through in order, sort of in progressive sequences of lectures, go through each of the guidelines, go through the use of brain monitoring for the treatment of these patients to sort of go beyond the guidelines, eventually work towards guidelines for surgical therapy, surgical treatment as well, and then talk about prognosis and outcomes in TBI. So really we're going to only go through the first three of these today, hopefully, if we have time. So traumatic brain injury is a very common problem. I think it's important to understand that this is a huge problem. There are 2 million brain injuries per year in the U.S., which is much larger really than a lot of other kinds of things that we deal with. It's extremely common. And there is sort of a progression of severity. So most of these injuries are sort of mild injuries, mild to even moderate injuries, or concussions. And there are types of concussions. So we think about this in severity: mild, moderate, severe, with concussion being the least severe, if you will. We see in the hospital, we see between 300 and 400,000 patients per year who come to get hospitalized and then move on to various forms of care. So it's significant. There are about 500 to 600,000 strokes per year. There are 30,000 subarachnoid hemorrhages. So this is much more common. It's orders of magnitude more common than subarachnoid hemorrhage. Sorry, Dr. Gonzalez. So there are various forms of causes of traumatic brain injury: auto accidents, falls, sports injuries, falling off your bicycle, and various kinds of events. Some of these are induced and some of these are not. There's also penetrating. We're not going to talk about penetrating today. But it's important to sort of look at the classification of brain injury and talk about concussion, mild, moderate, and severe. And these are the classical definitions when we talk about mild, moderate, and severe. Now, there's debate about this. There's debate that this is not the right classification, that we need a better classification scheme, a scheme that takes into consideration brain imaging, and that's sort of the future. When we talk later on in other lectures, we're going to talk more about the advances in this. And then there are imaging definitions of brain injury, where you can have a brain injury but have a negative CT and a negative MRI. You can still have a brain injury, a significant brain injury. We would classify that as mild or some form of concussion, but it's still a brain injury. Then you can have a negative CT but a positive MRI. So even if the CT looks completely normal, you can have an abnormal MRI scan. And then obviously you can have positive in both. And then you have the main types of lesions that we think about. And I think about these in sort of order of severity, where epidural hematoma is life-threatening, but as many of you have seen, many of the senior folks have seen, these patients are in dire distress, but they immediately wake up post-operatively. So the actual impact to the brain is less than it is for contusion, subarachnoid hemorrhage. And I actually put subdural and DAI as the more severe forms, and I hope to convince you of that as we show you the data on that. Of course, there are repeated injuries that can occur with various kinds of sports injuries. Pathology. When one considers classification of traumatic brain injury, one can also think about the particular types of pathology. What are the pathology of these various forms of injury? Well, the pathology varies depending on what happens. A concussion really does not have an actual tissue damage evident on a CT or an MRI scan. But there is movement of the brain. There is electrical disturbances of the brain that occur. Some people think that there's an acute depolarization or a seizure or some kind of spreading depression type of depolarization that occurs acutely. But there's no structural damage. And Dr. Hovda will show you in animals this in subsequent conferences. Then there can be a contusion in which there's actual hemorrhage into the brain tissue, probably due to a disruption of small blood vessels. Diffuse axonal injury really is the concept in which the brain twists and torques. It actually moves in an antero-posterior grade and also in a rotational grade in order to injure the brain tissues, the deep axonal tissues, as well as the vessels that run longitudinally. Then there can be extraaxial lesions. These are the epidural and subdural hemorrhages, obviously the veins and the arteries. And then penetrating injury, which is usually a contusional type of injury, which can occur at low speed, like a knife through the head, or a high speed, like a rifle bullet. So that the issue is, what happens with a concussion? Is there structural damage or not? There is clearly an electrical and a functional damage that occurs. And this is great, because the next slide actually goes to that exact point, where you can have a normal appearing CT and a normal appearing MRI scan, where the classic images, a T2, a T1, a T2, a flare, etc., does not show damage. But when you look at the more advanced imaging modalities, such as diffusion tensor imaging or tractography, you can actually see subtle changes in diffusion tensor imaging, the fractional anisotropy, or the actual tractography, where they look at the tracks as they go through, and they can correlate those subtle abnormalities, those on the advanced brain imaging, to neurocognitive dysfunction for long periods of time. So this is the general point of the average, the basic MRI may be negative, but you actually may still have a brain injury. And this is some work by Harvey Levin that shows in red and green and blue and all these nice colors the various tracks going through the brain that was developed through a diffusion tensor imaging. And there are highlighted regions of the brain, especially in the corpus callosum, where there are subtle differences between the patients who are normal controls and those that had mild concussion or concussion. Concussion can be defined various ways. This is important in sports medicine, and you may be exposed to this as a neurosurgeon, where people come to you and they come to you, you know, your daughter's soccer team, did she have a concussion? And they come to you because you're the brain expert. So you have to understand that there are really a classic form, really proposed by Dr. Cantu originally, of grades of concussion: grade 1 concussion, grade 2 concussion, grade 3 concussion. And each of these has various forms of duration of loss of consciousness, with grade 3 being the most severe, loss of consciousness greater than 5 minutes. And there are actually rules to return to play, or at least recommendations for returning to play, where if you have a grade 3 concussion, you should wait at least 1 month before returning to play if you're symptomatic for 1 week. And then if you're not, if you have continued symptoms, you should not return to play, or if you have a second concussion, you should not return to play. Having said this, these recommendations are minimally evidence-based. They're really not evidence-based. They are the evaluations of interested clinicians who are trying to figure out whether someone should return or not. Nonetheless, these are what are being implemented in various sports, especially at the grade school and high school level and college level. And they're trying to revise these. This is another slide showing the same kind of return to play kind of concept. If you have grade 3 concussions, then you should be out for some period of time. This is much debated. It's perhaps too aggressive. This is a great national interest and debate, but unfortunately we don't have great data. But I just want to make you aware of this. The other thing you should worry about, and we do worry about when we're called to make these kinds of evaluations, is this concept of the second impact syndrome, in which a patient has a one-time injury, it's a concussion, and subsequently then has a second injury, and they have a serious problem. They have a severe brain injury. They come to the hospital, and they in fact may have a brain image, or in some cases die, and they have pathology, actual pathology. And what you can see here on the list is a paper in '98, which is essentially a case series, but it demonstrates significant pathology ranging from contusion to edema to subdural hemorrhage to hydrocephalus when a person returned to play quickly after their injury. And we see this in the clinic. We see patients who come to clinic who have had a football injury and have a subarachnoid hemorrhage or a traumatic contusion, and they come and they say, "Can I return to play?" And there's basically very little data about this, but this is of concern. Now, how about moving on to moderate to severe traumatic brain injury? There are we've moved away from concussion, and now these are the injuries that we see a lot in hospitalized patients: contusions, diffuse axonal injury, and extraaxial lesions. Again, these are the location and types of abnormalities that are seen as listed in the slide. These are some pictures here that show a contusion, temporal contusion, as one can see, temporal contusion with enlargement of the temporal lobe, compression of the cisterns, early hydrocephalus. And this is the acute image, and the subsequent image shows expansion, hemorrhagic expansion and worsening of brain swelling with mass effect. This patient also has a little bit of a subdural, as you can see up above. Subdural hemorrhage, as one can see, is usually a more mass-like lesion, which is causing acute left to right or right to left shift in the brain. There can be various forms and various sizes. And the pathology of this is slightly different, as I hope to show you that this most likely causes acute Peel artery compression and is more prone for acute ischemia rather than other types of lesions. Here is another acute subdural hematoma, as you've seen before. This is an MRI scan now of a diffuse axonal injury. And what we see here that's different is we see that there are lesions involving the brainstem and deep white matter, and that these lesions are in part extracellular and intracellular edema, as well as hemorrhage. Hemorrhage plays a huge role in diffuse axonal injury. This is from a paper that was published online by our group in 2009 that makes the point of looking at various forms of MRI in conjunction with each other. It looks at diffusion-weighted imaging, and it looks at ADC imaging, and it looks at GRE imaging. So the diffusion shows these white spots, which are generally thought to be brain injury, but the ADC does not show concurrent reduction, but you do see hemorrhage. And so these are diffuse axonal injury is primarily a hemorrhagic lesion, hemorrhagic rather than a true ischemic lesion. And these are just various slices. The top row is one patient, the bottom row is a second patient, and what one can see is on the GRE sequence is a lot of blood in these regions. So diffuse blood, shearing of blood vessels, torquing of blood vessels. And it's a diffuse problem, and you don't necessarily see this on CT scan. You need a higher resolution sequence, an MRI scan to show this. The GRE sequence, the gradient recall echo sequence, or the SWI sequence, the signal weighted intensity sequence, makes use of the paramagnetic effects of blood, and it enhances the signal. So you can see small hemorrhage lesions inside of the brain. This is another MRI scan showing corpus callosum injury on DWI as well as T2, as well as hemorrhage on GRE. So corpus callosum and other white matter tracts are classic areas in which diffuse axonal injury can occur. And when we talk about prognosis, eventually we'll show that lesions in the corpus callosum especially carry a significant burden for poor prognosis. Said another way, if one has a corpus callosum injury, one's prognosis is worse, all other things being considered, than if the DAI lesions are not involving the corpus callosum. What is the pathology of DAI? We know this pathology both from the animal literature and from humans. David Graham and Dr. Adams many years ago published human pathology results of DAI. Here is a corpus callosum lesion on a section of brain, coronal section. Here is the tissue pathology showing what the axonal degeneration and the formation of these what are called bulbs or vesicles, if you will, these bulb formation, contraction balls of the axons. The axons are literally injured, torqued, twisted, broken, and then they contract over time. You'll learn in the animal literature that there are actually various forms of diffuse axonal injury. This is one of those forms. This process doesn't occur actually right away. This process takes time, and there's actually a clinical trial out proposed to try to interrupt that process. And the biology of that we don't have time to get into, but we've taken it really to the point of trying to interrupt that process. Now, we heard about our patient this morning that the cisterns were open. And so what does that mean? Well, that is a general way to evaluate the degree of brain edema, brain swelling, or perhaps brain injury in a particular patient. And what is this based on? It's based in large part on a grading system of CT scans, which was initially proposed by Larry Marshall from UCSD. And Dr. Marshall, it's been described in multiple ways, either 6 grades or 4 grades plus other lesions, but essentially tried to quantify, for use in a clinical trial, the kind of severity you see on a brain image. And of course, the more compression of the cisterns you have and the larger the brain lesion and the more swollen the patient's brain, the worse the injury. And what's thought to be kind of the worst injury is kind of the high volume, greater than 25 cc, non-evacuated mass lesion, a big mass lesion that's not operable, right? And then following that is probably the diffuse axonal injury type 4, in which there's midline shift and there's big volume inside of the brain. The brain is very swollen. But you can see that we go from a grading system of no visible pathology to cisterns present, but a little bit of a lesion, to type 3, cisterns are compressed or absent and a big lesion, to type 4, big time midline shift, big time brain lesion. And then you get down to evacuated lesion and a non-evacuated lesion. So the worse your grading is, the worse you are. And people will tell you about this. They might call you up and say, they have a Marshall grade 3 and I'm really concerned. Well, it's important to understand what are they talking about. It's having a general idea of what they mean by a Marshall grade 3. And we use compression of the cisterns as a key determinant point of who we're going to monitor and who we're not. Again, contusional injury is a little bit different type of injury that usually is a hemorrhage involving either frontal lobes anteriorly or temporal lobes anteriorly, and is associated with a fair amount of brain edema as well. So there's hemorrhage plus edema, and there's usually mass effect from this. The reason I put this up here is this is an MR spectroscopy slide. This is a multi-voxel MR spectroscopy slide that shows spectroscopy, and we don't have time to get into spectroscopy, but essentially if you look at this bottom voxel right here, you see this sharp peak here. That's a peak of what's called N-acetylaspartate, which is a neuronal mitochondrial marker. That's healthy tissue. That's a picture of healthy tissue. What one can see is in this area of edema, you have basically a loss of the healthy signals of the brain. So the brain is not metabolizing normally. The mitochondria are dysfunctional in that region, and you can see that pretty quickly with a spectroscopy. Now, having said that, one has to recognize that there are certain limitations of brain imaging, and if our radiologists in the room disagree with the interpretation of that, that's fine. I acknowledge that. There are issues. But this basically tells you the kind of pattern that one would see and tells you about the biology. Okay? Now, this is the timeline of pathophysiology that I want to spend a considerable time on over the course of this lecture and other lectures. There is a timeline, just like subarachnoid hemorrhage, where there are sort of phases of the disease. There are phases of the disease in traumatic brain injury, but the phases, if you will, are somewhat blurred. But it's important because if you think about the pathophysiology, you can actually try to determine what you're going to do when, and what you're going to do. The actual treatment may change based on the timing and what's occurring. So we're going to focus here on the first 48 hours, more or less, and what happens acutely. Well, you have a trauma acutely, and you may have seizures occurring very acutely, and early on you have apnea and hypotension. Subsequently, you have hemorrhagic expansion, and I put in percentages here, and these slides are available to you so you don't have to write all this down, but I put in percentages here that are based on what the literature suggests, that various problems occur more to a greater extent or to a lesser extent over time. Hemorrhagic expansion, then you have later hypotension, brain ischemia, elevated ICP, hyperglycemia, aspiration pneumonia. And the treatments that we think about early on for this, obviously, are evacuation, surgery, resuscitation, ICP treatment, anticonvulsants. And there may be other things in terms of like treating hyperglycemia, which we'll get to. So I want to focus in on this early period, the trauma period and the early coma period, to talk about what's happening. In the early coma period, you have the various similar kinds of things, but then you have ongoing low blood flow. So hemorrhagic expansion. This is something that we see a lot. We saw in this particular patient that was presented this morning. But I don't think we truly appreciate how significant this problem is. Hemorrhagic expansion, this is another patient who's in the ICU right now. Patient comes in with this frontal contusion, and then they start expanding. And this expansion basically occurs in over half the patients with parenchymal injuries. And we've seen this here at UCLA, and Dr. Narayan has seen it at the University of Cincinnati. And it's not clear why this occurs, but it does occur in a lot of our patients. And one of the prevailing theories now, it's probably not the only theory, but one of the prevailing theories, and for which we've been seeing a clinical trial underway, is that there is a factor 7, activated factor 7A deficiency that occurs. And what's thought of, this slide shows you what's considered a thrombin burst to seal a bleeding blood vessel. And this thrombin burst is very dependent on activating factor 7. Essentially, when you have tissue injury, tissue factor is released. This activates, this engages factor 7. Factor 7 then causes your whole thrombotic platform to occur. It activates platelets, and you get a platelet plug, and then that then leads to a fibrin plug. And what happens, what has been seen is that one is deficient with factor 7 after various forms of injury, including traumatic brain injury. The literature is about 15 to 20 years old in this area, but recently Dr. Narayan has performed a phase 2 type randomized controlled clinical trial, a dose-finding, dose-ranging trial in traumatic brain injury, where he gave one of 4 doses actually, of factor 7A to determine whether factor 7A given to the acute traumatic brain injury patient would result in less hemorrhagic expansion. That was the hypothesis. And this was a placebo-controlled trial. It was, there are only 97 patients across all of these doses, so it's underpowered. It's phase 2. And what they looked at predominantly was the expansion of hemorrhage. They wanted to see, from the biology standpoint, does this block the expansion of hemorrhage? Very simple. They're not powered to determine outcome. And these were the data. It's kind of hard to read from the back of the room, but the lower box here in blue demonstrates that in all of the factor 7A doses combined, there was a 10% hemorrhagic expansion at 24 hours. 10% of the initial patients had this hemorrhagic expansion versus 21% expansion in those patients who got the placebo. And at 72 hours, there was a similar kind of difference. So their primary hypothesis is held up, that factor 7A limits the hemorrhagic expansion acutely for these kinds of patients. Again, this is not ready for prime time. This is not ready for treatment. You can't walk away and say, this is the treatment and it's proven. This is just showing you the biology. This may be an avenue for treatment in the future for these patients. Now, moving on, within the first, again, 24 to 48 hours, what is the pathophysiology that's occurring? Here at UCLA, we've been studying brain metabolism. Dr. Bergschneider started several years ago studying brain metabolism and noted that early on, within the first 5 days or so, there's this increase in glucose metabolism in the brain. And Dr. Hovda will talk to you about what happens in animals, but this is a composite, if you will, based on real human data of what happens after brain injury. And it's a very complicated slide, but I'm just going to point a few things out for you. Acutely, after a brain injury, there's a relative increase in excitotoxicity. Your glutamate levels inside of the brain go up. We know that from microdialysis research. And there's electrical depolarizations going on, and this is fueling, or this is demanding metabolism, and there's an increase in glucose metabolism shown in this dark little orange slide here. At the same time, there's a relative reduction of blood flow. Blood flow does not go up, rather it goes down. So you have early on, and at least in some patients, for some period of time, a lot of which we don't know how long that occurs, an imbalance between energy demand and energy supply. So metabolically, there's an abnormality going on in these patients. And it seems to be a global phenomenon. It seems perhaps to be more related to the area of surrounding an injury in some cases, but it seems to be global as well. So this is a picture of a patient with a subdural and an evacuation, and these are three different PET scans. This is a blood flow PET scan, this is a glucose metabolism PET scan, and this is an oxygen extraction PET scan. And what you see here is there's a reduction in blood flow in an area that doesn't look too bad, really, on brain. It's near the area of injury, but it's not really damaged totally. But this is glucose. Glucose is preserved. Low blood flow, preserved glucose. It's a little lower than the other side, but it's not as depressed as much as blood flow. And oxygen is reduced as well. What we've come to see is that oxygen metabolism goes down, most likely due to poisoning of the mitochondria. So at a time when you need energy, you don't have your normal mitochondrial function occurring. Okay? So during this time of brain edema, brain swelling, there's this metabolic cascade, metabolic abnormality that's occurring. Cerebral edema occurs early on, within this first 48 hours, if you will, and it gets worse and progresses over time. And most of the cerebral edema that occurs is due to excitotoxic brain swelling, or cytotoxic edema, for the most part. This is a slide taken from a pathology series from Ross Bullock in which the patients had high glutamate levels, and this patient had cerebral edema and went on to die, and then they could get an autopsy. The whole cell is markedly swollen. This is the nucleus. These are the mitochondria on electron microscopy. Excitotoxic cerebral edema that's ongoing. The edema also potentially could be related to diffuse effects from impaired autoregulation or leaky blood vessels. So there could be a leakage of fluid through blood vessels. Some people would call that a vasogenic type of edema. But it's different. It's really not truly vasogenic in the sense of a neoplasm having abnormal blood-brain barrier. They have impaired autoregulation, impaired blood-brain barrier for various states. And at the same time that edema is occurring, you have variable states of cerebral blood flow. And some of this edema is due to excessive blood flow. When we talk about monitoring, in a subsequent lecture, we'll talk more in detail about autoregulation. We have autoregulation as part of our neurocritical care series. We're not going to spend much time on it. But just to sort of reference that there are some people who have impaired autoregulation, and that is going to lead to increased blood volume and increased ICP, and perhaps increased brain edema as well. Early on after brain injury, with this brain edema, and with the occurrence of hypotension, which occurs in a high percentage of patients, 30 to 40% of patients, you can have secondary ischemic brain injury. And this is basic science data from Jenkins et al. At Medical College of Virginia about 25 years ago, showing that if you injure an animal, you give a traumatic brain injury plus ischemia plus hypoxia, you wipe out the hippocampal neurons. These are hippocampal neurons being sort of normal and then being wiped out. And so the brain is incredibly vulnerable after a brain injury for a long period of time. Ischemia is thought to occur in the most severe brain injuries, those that become fatal. This is based on data from David Graham. This is one of the slides from Adams and Graham's papers. This is the hippocampus, and one can see this is a crescent violet type stain, so neurons should stain dark, and you can see all the white areas here where there's cell death, actual cell death in the hippocampus due to ischemia. So ischemia may play a role. Initially, within the first 6 to 12 hours, it has been demonstrated that 30% of our patients have brain ischemia. That's been done by jugular venous studies done in the emergency room or other kinds of studies. And that this low cerebral blood flow may occur globally or near contusions. Later on, we see that blood flow is low but not necessarily ischemic. And this is a point that is difficult to reconcile in some ways. So you can have low blood flow but not necessarily ischemia. But early on, within that first window that we're talking about, you have to worry about ischemia, most definitely. This is a PET study from Cambridge showing within the first 24 hours of brain injury, they got their patients in and they got them to the PET scanner right away. We won't talk about this. This is a great feat, really, for them to do. And this is a patient who has a subdural. Again, I mentioned to you subdural hematoma, compressing the PO arteries, PO vessels. They did a hemicraniectomy, but they didn't do it that successfully because the brain is still pushed in, there's midline shift, and the hemorrhage is still there. And the brain underneath that subdural is ischemic, which is shown in here in white, which is the oxygen extraction fraction. These red segments are the areas that are ischemic in what's called the ischemic brain volume mode. And about 6%, 7% of the brain, on average, across a large cohort of patients are ischemic early on. In this particular patient, about 35% of the brain is ischemic in that particular patient. So especially subdural hematomas that are not properly evacuated or evacuated early can have brain ischemia. So that's a real that's a different kind of emergency. That's a different kind of situation than some of the other things that we deal with. And underneath the subdural, here's another paper, Claudia Robertson's group, where they studied the pathobiology underneath the subdural. And what they found was, underneath that subdural, that the brain tissue oxygen values were pretty low, shown here in the open circles, pretty low. The ICP is high, and that the microdialysis markers show ischemia. So again, underneath that subdural, that brain, until otherwise proven, an acute subdural that's not evacuated, they probably have active local regional ischemia. That's a different biology than what we see around contusions. Now, ischemia can occur globally and otherwise regionally. Here's one of our patients from many years ago who had a jugular bulb catheter in place. Jugular bulb catheter comes up and sits right at the jugular bulb, inferior part of the transverse and sigmoid sinus there. And here it is on a CAT scan, that white catheter sitting there. And early on, this patient has high ICP, shown in blue, and very low jugular catheters. This patient is probably ischemic, and that's related to the high ICP. But later on, hour 30, patient's no longer ischemic, and actually is hyperemic. So as I said before, there are phases of biology that occur, and we don't know in the individual patient which phase a patient is in, and they may be ischemic or they may be hyperemic, and the jugular catheter or other techniques are able to tell us where they are in terms of the biology. But again, focusing on in that first 24 hours, ischemia is prominent. When people have done these kinds of experiments, and it's been done by two different groups, both in the US and in France, they've shown 30% of patients are ischemic in the emergency room when you get to them and you plop the jugular in. Part of that is high ICP, and part of it is hypotension. Okay, so highest risk in initial 12 hours, the SjO2 is less than 55%. This can be triggered by excessive hyperventilation to CO2 is less than 25, hypotension, blood pressure is less than 90, high ICP, or a large subdural hemorrhage. This is what I just essentially told you. Later on in the time course, patients can become hyperemic, and how do you know if they're hyperemic? Well, one of the methods to know, to determine this is the SjO2 greater than 75%. Later on in the ICU, a different sort of pathobiology occurs where ischemia plays less of a role, but the brain is still in metabolic crisis. In other words, the brain is behaving like it's ischemic, but when you measure the actual oxygen consumption, it's low. It's not high, as you see in ischemia. And again, starting with Dr. Bergschneider and Christine Wu and others, over the course of time, we've demonstrated with both PET and combined PET and microdialysis data that patients have ongoing metabolic distress as indicated by this microdialysis marker, but they don't have ischemia. We've recently revisited this and looked at blood flow values in global regions, blood flow values in the border zone between ACA and MCA, like you may see with a carotid occlusion, And we don't see evidence of ischemia by any of our markers, the oxygen extraction marker, fraction marker, or the blood flow marker, or the CMRO2 marker. And when we actually look by MRI scan, and we look for areas of diffusion-weighted abnormality, we find that they're not ischemic. What we see is that they're hemorrhagic. And the hemorrhage is causing this kind of pathobiology. So what can cause this metabolic distress that's ongoing? Sort of the next phase of pathobiology, pathophysiology, which are occurring in these patients. What can cause this? Well, there are a variety of things that can cause this kind of phenomenon. Seizures are one of them. Seizures are pretty common after traumatic brain injury within the first 7 days, 20% to 25% in our series, and that's been replicated now in half a dozen other centers doing this kind of work. The other kind of electrical disturbance that we think is occurring at a similarly high incidence is something called spreading depression. And the British have led the way with this, Tony Strong and others, and Jed Hardings here in the United States, show that there's a migraine type of spreading depression, depolarization, that occurs in, again, a large number of patients, 20 to 30%. And this seems, these have been measured in the pericontusional areas, and so there may be a difference as to what's going on where. There may be various regions of the brain having different kind of electrical instability. But electrical instability, electrical brain arrhythmias, if you will, may be one of the principal sources of this ongoing distress. That remains to be proven. That's a hypothesis. Obviously, cerebral edema and high ICP, the brain is unhappy. There's progressive increases in ICP that will cause distress. Cell death may be going on. There's an area of primary brain injury, cell death. Those cells are dying, but they're releasing their contents. They're engendering an immune response. They're engendering they're leaking out all of their toxins, and that's another toxic injury that may be driving metabolic distress. We know that in cells that are normal looking in appearance, that their mitochondria are dysfunctional. Even normal appearing cells, and clearly the areas that have the edema, like I showed you the spectroscopy, are impaired. And there may be an oxygen deficit. There's a novel hypothesis out there that walks the fine line between classic ischemia and lack of oxygen. Now, when you think about it, you're like, well, if you don't have enough oxygen, then that's ischemic. But there's a theory, actually, that the mitochondria are not working well. And with normal levels of oxygen, the mitochondria can't respirate. But if you give them hyperoxia, if you ramp them up to 5, 6, 7 times atmospheric oxygen partial pressure, 500 PO2 or similar, the mitochondria can actually start to respirate. Interesting hypothesis. Needs to be, David Menon from Cambridge has espoused this, but it needs to be demonstrated. There actually is a randomized controlled trial about hyperoxia in which this actually occurs. You give hyperbaric oxygen and metabolism goes up. So there's data in humans that this might be one of the causes of this distress. So this is a paper from 99 that showed seizures in this population of patients done here at UCLA. And a recent EEG, more recent than that, in a patient with traumatic brain injury. We presented this at the ICU the Future conference last year. And what one can see is on the EEG, you see these polyspike and wave, polyspike and wave, polyspike and wave seizures that are ongoing. This patient's in status. And seizures by themselves are frequent, 20 to 25%. The incidence of status in a patient with traumatic brain injury really is uniformly leads to death, at least in the initial paper. Hyperglycemia. Hyperglycemia is one of those pathophysiologic events that occur that may actually impair long-term outcome. Dr. DeSalis, many years ago at Medical College of Virginia, was one of the first to do a prospective study to show that if you're hyperglycemic early on within the first 24 hours, you're going to have a worse outcome. And there have been a few other studies that have demonstrated similarly this relationship. In a more advanced analysis of this, it was demonstrated that the lower your GCS, the higher your glucose is in emission, so there might be a severity of injury issue. So not necessarily an independent effect of hyperglycemia on outcome, but rather a correlation. And there have been a few other studies that have demonstrated this same kind of phenomenon. But interestingly, when we start to apply insulin therapy to normalize glucose in these patients, we see that maybe there's a signal towards improved outcome, but maybe there isn't. And this is an area of debate. as to what to do later on in those periods, not within necessarily the first 24 hours of injury when someone's hyperglycemic with the glucose greater than 200, but what to do later on. And we'll cover that as we talk about brain monitoring. Now, systemic changes that occur early on after traumatic brain injury can be summarized in this slide. And each of these actually may play a role in worsening the pathobiology, pathophysiology of the brain injury itself. For example, as we just talked about hyperglycemia, but hypotension. Hypotension occurs, again, 25 to 30% of our patients. We did an analysis now, it's been 10 years ago, but we analyzed how many of our patients had a big level 1 trauma center in which, you know, we have a whole trauma team and an ED. How many of our patients are actually hypotensive in the field or in the ED? And it's about 30%. So this is a significant problem that one needs to pay attention to when doing an emergency room consult. Adrenal insufficiency can be a common phenomenon after traumatic brain injury. Again, we've done research here at UCLA. Dr. Kelly, while he was here, did a multi-center pituitary insufficiency study and found adrenal insufficiency in a substantial number of patients, 20 to 30%. And so these patients may be acutely, within the first, again, 24 hours, adrenally insufficient, and that may play a role in the pathophysiology. Fever is almost universal, and it's been moderately to poorly studied in patients, but it may play a role in brain metabolic dysfunction. Our patients are catabolic. Unknown as to what role this really plays. We know it occurs, we know we should feed them early and that feeding early improves outcome, but we don't really know what effect this has. And the coagulopathy, which I've already covered with the factor 7 story that we talked about. So these data, and some of these data and some other data that I haven't yet shown you, have really led towards this concept of guidelines for therapy. And the AANS, CNS, and some other groups working in conjunction with them over the years have come up with a evidence-based set of guidelines for the treatment of traumatic brain injury and have tried to identify a number of areas where data exists. And we're going to go through these really in our next set of lectures. But essentially, many of the things many of the initial set of recommendations are based on this acute pathophysiology. Don't let the blood pressure be low. Well, why? Well, because we have evidence that it's bad, and we have evidence that there's brain ischemia early on. That makes sense. And then there are a variety of other kinds of recommendations that we're going to go through in detail. Most of these are what are called level 2 recommendations. Level 1 means you have multiple randomized controlled trials, or at least one good randomized controlled trial to support a thesis. And that X works and it's proven and therefore one should do it. For most of traumatic brain injury, we don't have that. We have level 2 data. The only thing that we have for traumatic brain injury that's a level 1 recommendation that's based on randomized controlled trial is don't use steroids. And there's multiple randomized controlled trials that say steroids worsen outcome after traumatic brain injury, worsen mortality after traumatic brain injury. The ICP guideline, monitoring guideline, so we alluded to this in Aaron's presentation. The patient was a Glasgow Coma score 7T. Basically, guidelines, GCS 8 or less, so moderate to severe TBI, which means GCS 8 or less should get it, or if there's evidence of this brain edema. So if you have these Marshall class 3 or class 4 type of abnormality on your CT scan, then one can suspect that ICP is going to be elevated. Now, we also use it when these are sort of softer calls, but we use it when we're going to lose our exam due to chemical paralysis anesthesia. They're going to the operating room, which we experienced, or and this is actually written into the guidelines, normal CT scan but with posturing or low blood pressure, age greater than 40. And this is getting at diffuse axonal injury. This is the concept that we cannot see diffuse axonal injury on a CAT scan. And so if the CAT scan looks normal, it may not actually be normal. And our radiologists may read this as normal because they're looking for big things. They're not looking for, they cannot tell DAI. They don't have the diagnostic discrimination ability for that. And so that's what's actually written into the AANS guidelines. Okay, so do we have we're going to do audience response? Okay, we'll do audience response by show of hands. So residents are encouraged to participate. Okay, so questions. This is being recorded, right? At initial impact in TBI, the following is the first thing to occur. A, electrical depolarization. B, cerebral edema. C, brain hemorrhage. D, amyloid deposition. So how many are going to vote for A? Show of hands. Okay, good. You're right. You're a very smart group. Amyloid deposition, I just kind of put in there, is more of a delayed phenomenon. It's an interesting thing in and of itself. Dr. Bergschneider is trying to study this. Also, and there's been some data about this, very interesting about the whole pathobiology. If you're genotype E, then you're going to have a much worse outcome. You're going to have more amyloid deposition than if you're, ApoE, than if you're not ApoE4 positive. If you're ApoE4 positive, then you're going to have more amyloid deposition, worse an outcome, more dementia, so forth. So before you go, before you enlist in the cross-country motocross circuit for your time off and buy that Ducati motorbike, get your ApoE4 checked. Okay, so if you're, ApoE4 negative, go for it, do it. Okay, question 2. Ischemia after TBI occurs in each of these situations except globally when ICP is greater than 60, regionally when a large subdural hematoma is present, transiently when a systolic hypotension, systolic blood pressure less than 90, or regionally with a brain contusion. So which is not correct? Who votes for A? Who votes for B? Who votes for C? Who votes for D? D. So this is the phenomenon where the blood flow is low, but there isn't ischemia surrounding that. Because this is actually important. For many years we thought contusion, low blood flow. Don Marion actually demonstrated quite nicely that the blood flow is very low surrounding a contusion, and if you hyperventilate them, they become even lower. And that got us all thinking that's ischemia. And therefore, we were changing our treatments to try to avoid that. But in point of fact, our PET studies and the Cambridge PET studies and the Washington University PET studies, the 3 centers that have done these kinds of PET studies, have shown it's not ischemic. It's low, but it's not ischemic.
Curiously, even though there is a lot of discussion regarding that type of images, in the slide that you have with the MR spectroscopy, in the areas of contusion and around, there was really not an increase in the peak of lactate that you would expect if there was ischemia. So even though that was not the point of that slide, it kind of goes in the same direction that ischemia was not at least a problem in that.
That's right. That's right. We in spectroscopy imaging studies, they've not seen this perihematomal increase in lactic acid that one would see with an acute ischemic stroke. Okay, next slide. Next question. Diffuse axonal injury affects all of the areas except A, corpus callosum, B, brainstem, C, optic chiasm, D, hypothalamus. So the one, which one does not involved? How many vote for A? How many vote for B? How many vote for C? How many vote for D? Okay, C is probably the best answer. Now, why do I put this question in here? I put this in here because obviously corpus callosum and brainstem are the classic areas. They're important. They have prognostic implications. The hypothalamus is important because these patients become hypotensive and become adrenally insufficient. And there's a concern that actually, and you actually see damage in the hypothalamus on GRE from time to time, that they may have this adrenal hypopituitary adrenal axis insufficiency. So it's an important concept to revisit. The optic chiasm we don't necessarily see. Our patients, long term, they don't end up blind. If they survive, they can see just fine. They don't remember what they see. That's the problem. Okay, question 4. TBI results in all of the following except A, early seizures, B, hypoglycemia, C, adrenal insufficiency, D, cerebral hyperemia. How many vote for A? Whew, that was good. I wish. How many vote for B? How many vote for C? How many vote for D? Yeah, so hyperemia occurs later. Early on it's ischemia. Later on it's cerebral hyperemia. Dr. Martin's group really published that a number of years ago now, that there are phases of cerebral blood flow. Ischemia early, hyperemia later, maybe vasospasm downstream. Okay, and hyperglycemia occurs early on. Okay, question 5. Which best characterizes the relationship between ICP and CBF? Okay, ICP and CBF. early after traumatic brain injury, CBF is low when ICP is elevated. B, early after traumatic brain injury, CBF is high when ICP is elevated. C, later after TBI, CBF is low when ICP is elevated. And D, later after TBI, CBF is high when ICP is elevated. So early means first 12 hours, later means 48 hours and beyond. So A is early TBI, low blood flow, high ICP, and so forth. So how many vote for A? Okay. How many vote for B? Early on, blood flow is high. How many vote for C? CBF is low when ICP is high. And how many vote for D? Later on, CBF is high when ICP is high. Okay, so this stumped everybody, which is the point of this slide. Because really, A is true. CBF is low and ICP is high. You have that disproportionate problem. You may have ischemia early on. Think about that acute subdural hematoma. The ICP is high. You haven't done anything. There's no ventric. You know very well. You pop a ventric in that patient, their ICP is 50. That's the first ICP. And their blood flow is low. And then later on, D is correct, because ICP can be high and the cerebral blood flow can be high. And as we get into monitoring in our next lecture, when we show you monitoring and how we're using the monitoring, we'll show you more about the high blood flow and the high ICP. And that's the end of part 1. Questions? Yes?
In the last slide, the mechanism